Hi, I'm Mary McCulkin, and this is my brief history of epidemiology. I was in Athens and I read that there was an infectious disease museum exhibit, so naturally I went to go check it out. In 1992, the Greek government started construction for a new subway station near the Keramikos Cemetery, and in the process of drilling for the new subway tunnel and digging for the subway station, they uncovered multiple mass graves. One found in 1992 had more than 150 people buried in it, and another mass grave was found in 2001. Altogether, they found more than 1,000 people who were buried in a haphazard, chaotic manner that differed dramatically from the traditional way of burying people, which provides evidence that they died of the epidemic, which had 3 waves over 5 years during the Peloponnesian War. What's really remarkable about that epidemic is that Thucydides, who was a famous historian of that era, wrote a detailed first-hand account in an effort to inform and prepare people in the future should the same disease cause another epidemic again. After seeing the gigantic hole in the ground where the Greek government ended up canceling the project to build a subway station there, I then went to the National Archives where they have Thucydides' first-hand account. And it was incredible that it's still preserved. You can still read his handwriting describing what he was witnessing. And he went on to describe when he himself fell ill during the epidemic. Reading his detailed first-hand account of what he was observing and seeing where this mass grave had been excavated, and knowing that the archaeologists had been able to confirm that the piles of bodies that were hastily buried date to the same years when he was describing this mass casualty event was incredible. It was hard to believe that his handwritten document that still exists in good condition, preserved in the museum, is from 430 BC. And we have physical archaeological evidence to confirm his account and to provide further evidence. He did a remarkably good job describing the epidemiology of this epidemic, especially given that epidemiology as a field didn't exist yet. Some scholars have criticized his clinical descriptions as being imprecise, but I don't think that criticism is warranted. He described the symptoms as including fever, headache, vomiting followed by diarrhea. He talked about an unquenchable thirst that led some people to throw themselves into cold bodies of water or even wells in an attempt to provide symptomatic relief, and described bloodshot eyes with hemorrhaging. Some of the criticism of his account focuses on the exact word in Greek that he used to describe the skin lesions. Many researchers had translated his description of the skin manifestations of the illness to be pustules, and that led researchers to think that the epidemic may have been caused by smallpox. But the word in Greek that Thucydides used is the same word that Hippocrates used to describe contact dermatitis. And Thucydides did not specifically describe vesicles or bullae, but his descriptions overall were very precise. So it's reasonable to assume that had they been present, he would have mentioned those unique characteristics. From the written description he did provide, if you imagine a rash all over the body that resembles contact dermatitis, the skin would be fragile and flaking and falling apart, and people would be bleeding all over their body as their skin is breaking. That rash wouldn't be consistent with smallpox, but it would be consistent with Ebola. So I think if you have a more flexible, imaginative interpretation when reading what he actually did write, and give him a little bit of leeway given that epidemiology didn't exist yet and he was not actually a physician, he did a remarkably good job describing the epidemic. He provided the disease duration. Most deaths occurred 7 to 9 days after symptom onset. He approximated the attack rate. He said more than half of those infected he observed died of their illness. The infection conferred immunity. He said those who survived and were exposed again did not fall ill a second time. And he provided clues about the route of transmission. The community initially thought that their wells had been poisoned as part of the war, but as the infection spread to the main city, it was clear that the route of transmission was not through water. The more contact doctors had with people with the infection, the higher their own risk of death, and the infection killed whole families. People of all ages, genders, and all races, including immigrants from other countries, were all affected equally by the infection. He wrote that it originated in Ethiopia and spread into Egypt and Libya before arriving at the port of Piraeus, and from there it spread into the main city of Athens. He paid careful attention to the effectiveness of medical care provided and other interventions tried, but because none were effective, the best he could do was to describe that all of these measures were ineffective. Modern researchers previously thought the Ebola virus first jumped from bats to humans in 1976. But more recently, evolutionary biologists identified Ebola DNA within the genomes of the Norway rat and a mouse, which means Ebola was present at least 20 million years ago, before the mouse and the rat evolved into different species. The book On Air, Water, and Places was published just 30 years after Thucydides' description of the epidemic. Hippocrates was a Greek physician and an influential figure in the development of both the medical profession and epidemiology. He theorized that disease causality can be attributed to differences in individual health behaviors, including nutrition and exercise, and environmental factors, including seasonal variations and geographic location. For example, Hippocrates observed malaria and yellow fever occur more frequently in warm, swampy areas. He was the first to examine the relationship between disease and the environment. He emphasized the importance of careful observations, and he sought logical explanations for the causes of disease. This was in stark contrast to the prevailing way of looking at health and disease at that time, which promoted theories of disease etiology rooted in religious and superstitious beliefs. He distinguished between endemic and epidemic diseases, wrote the first case series, and described health outcomes in terms of morbidity and mortality. There are more than 70 books attributed to Hippocrates, and most academics now favor the term Hippocratic corpus to refer to these texts, because they were written by many different people over a period of several centuries. There's debate whether any of these texts were actually authored by Hippocrates himself, but the legend and the influence live on. Bubonic plague is caused by the bacteria Yersinia pestis, which is a gram-negative coccobacillus. Fleas get infected by feeding on an infected mammal, then the infected flea bites a healthy rodent and regurgitates infected blood into the bite wounds, which allows the bacteria to enter the animal's bloodstream. Humans are considered an incidental host because they don't contribute to the disease cycle. Flea bites are the most common route of transmission to humans, but infection can also occur from cat scratches or bites, breathing aerosolized droplets from an infected person, or contact with the body of someone who died of plague. Bubonic plague causes fever, headache, joint pain, vomiting, one or more buboes, and gangrene, which is where the name Black Death comes from. When the bacteria enters the lymphatic system and travels to a lymph node, it collects there and causes swelling and pain as the enlarged lymph node develops into a bubo. The case fatality rate ranges from 50 to 90% within 8 days without treatment with an antibiotic such as gentamicin, doxycycline, or levofloxacin. Plague has afflicted humans for thousands of years, and 3 major pandemics of bubonic plague have been recorded in human history. The plague of Justinian started in Egypt in 541 AD and quickly spread to all countries bordering the Mediterranean Sea and extended as far as Ireland. That strain kept circulating in at least 18 waves for the next 200 years, and it killed about half of Europe's population. The second pandemic spread from Western Europe across the continent and all the way to Greenland in 1350. That strain caused waves of plague in Western Europe for the next 500 years and killed about a third of the population. The leather mask with a long beak, worn by plague doctors during the second pandemic, was filled with perfumes, spices, and flowers. It originated from the ancient theory of miasma, or bad air, which was a prevailing theory of the cause of infectious disease before microorganisms were discovered as the cause of infectious diseases. So the beak-like mask wasn't just to protect against the smell of rotting flesh. They actually believed it would prevent infection. The third documented pandemic started in China reached Hong Kong by 1894, then spread globally on steamships and along trade routes. The plague bacillus was isolated during this third pandemic by Alexander Yersin, so the genus Yersinia was named after him. DNA from human teeth from Asia and Europe, dating back as long as 5,000 years ago, confirms that all three of these plagues were caused by Yersinia pestis. But there's evidence that the ancient strain had important differences and may have had a different means of transmission compared to the modern plague, for which fleas are the vector. The first plague pandemic moved much faster, even faster than the 1918 flu pandemic, which is one clue it may not have relied on humans and rats walking around. There were differences in the clinical presentation of the illness it caused, and mortality was much higher. It was described as being highly contagious, while more modern plague is much less contagious. Sick rats were not documented in the first or second plague pandemics, while they're closely associated with the third pandemic and with modern plague. Early plague was associated with famine, while the third and more modern plague is linked to grain silos and abundant food, which rats can feed on. There's also differences in geographic and seasonal variations. Early plague started at any time of year, before settling into a pattern of higher transmission during the hottest, driest months, which are fleas' least favorite conditions, while plague of the third pandemic occurred in warm, humid weather, which is favorable to the subtropical rat flea. Early plague was worse in rural areas, while the third plague was worse in cities, and has been associated with overcrowding. One modeling study suggested that body lice, rather than fleas, may have been the primary vector for plague prior to the third pandemic. Modern plague is endemic in wild rodent populations around the world. In the US, most cases occur in Arizona or New Mexico, with an average of less than 17 cases confirmed annually in the US. Colonialists from England, Spain, and France caused the deaths of more than 90% of the population of Native Americans by spreading diseases including smallpox, measles, and typhus, which were common back in Europe but didn't exist in North America, so the Native Americans had no immunity to these infections. The population was decimated to less than 1 million people by 1640. John Graunt is known as the founder of demography, which is the statistical study of populations. He invented life tables, which present mortality data in terms of age-related probability of survival. For example, he used a life table to show that 36% of children in London died before reaching age 6. His analysis of the London Bills of Mortality noted disparities between men and women, lower life expectancy of city dwellers, quantified immigration from the countryside to the city, documented patterns of disease occurrence, and quantified infant mortality. He was the first to document excess deaths during epidemics. He attempted to calculate a case fatality rate during an infectious disease outbreak and distinguish between acute and chronic diseases. Graunt provided a template for quantitative analysis of demographic and health data and developed the concepts of statistical association, statistical inference, and population sampling. Smallpox was a viral disease that caused fever, headache, vomiting, a pustular rash that caused permanent scarring, and left some blind. The case fatality rate was 70% among pregnant women and 30 to 50% for others. One of the first methods of controlling smallpox was variolation, a process named after the virus that causes smallpox, variola. During variolation, people who had never had smallpox were exposed to the material from smallpox pustules by scratching it into their arm. People would get a mild case of smallpox, but fewer people died from variolation than if they had acquired smallpox naturally. In 1768, country doctor John Fuster made the clinical observation that a group of farmers who had recovered from cowpox were all immune to smallpox when he tried to inoculate them via variolation. According to medical historian Dr. Arthur Boylston, the famous milkmaid story was likely fabricated after Jenner's death by his biographer. Based on letters, diaries, and medical notes from the time, as a 13-year-old orphan, Jenner was apprenticed to two doctors who heard about Dr. Fuster's clinical observations at a meeting of doctors and likely passed along the story to Jenner when they got home. In 1796, Jenner tested the theory that exposure to the relatively mild disease of cowpox would protect people from the far deadlier disease of smallpox. He vaccinated James Phipps, the 8-year-old son of his gardener, with pus taken from a cowpox pustule from the milkmaid Sarah Nelms. And it worked. The boy proved immune when exposed to smallpox after vaccination with cowpox, as did several other children Jenner experimented on, including his own 11-month-old son. Jenner's work went down in history as the first scientific attempt to control an infectious disease through vaccination. Thomas Malthus predicted that natural population growth would inevitably outpace agricultural output, ultimately resulting in disease, famine, and war until the population was reduced below a sustainable level. Depicted on the left, he theorized that population growth would increase more quickly than it would be possible to increase resources such as agricultural crops, and when the limit of subsistence is reached, there would be a point of crisis, also known as Malthusian catastrophe, when war, disease, and famine would result, causing the population to decline. Malthus's theory is based on the premise that the amount of crops that land can produce and the amount of water available and other resources needed to support human life are not unlimited. The land mass of the earth can only support so many people. To prevent catastrophe, Malthus recommended controlling family size, so poor families in particular wouldn't have more kids than they could support. Interestingly, birth control hadn't been invented yet, so the main preventive measure he recommended was placing restrictions on marriages. Malthus's view that poverty, disease, and famine were natural outcomes of population growth was very unpopular among social reformers of the time, who believed that proper social structures would eradicate all people's problems. Discussing population control has become even more taboo since Malthus's time. When accepting his Nobel Peace Prize for the agricultural advancements that led to the dramatic increase in global grain production in the 1970s, which supported increasing populations, agricultural scientist Norman Borlaug warned that the Green Revolution's success bought about 30 years of leeway, but disease, famine, and war, predicted by Malthus, would catch up to us unless bold action was taken to reduce fertility rates. China reacted by creating its one-child policy less than a decade later to prevent this impending crisis. One of the most ethically dubious aspects of Malthus's theory is that he specifically blamed the lower classes for being irresponsible with how many children they were having. But his theory did influence Charles Darwin's theory of natural selection and has been influential in the field of epidemiology as well as demography. The General Register Office for England and Wales was established in 1837 to record births, deaths, and marriages, and to conduct the national census. William Farr built upon John Graunt's work by systematically collecting and analyzing mortality data to compare rates between different professions and residents of different areas. He constructed a series of national life tables, demonstrated that the distribution of smallpox deaths during an epidemic followed a normal curve, and is considered the founder of modern vital statistics and public health surveillance. He demonstrated with data that the environmental conditions within the mines the workers were exposed to were the cause of the miners' high mortality rates. And he joined forces with Florence Nightingale, who is advocating for evidence-based changes to improve the health of soldiers during the Crimean War. Florence Nightingale shaped the nursing profession and used statistics to advocate for evidence-based changes to clinical care. She's well known for insisting that hospital patients have sunlight and fresh air, which was in contrast to the dark, overcrowded hospital wards of that time. Nightingale's epidemiological investigation, supported by Farr, demonstrated the importance of environmental cleanliness to prevent disease transmission in hospitals. They used incidence rates and incidence proportions to support her arguments for hospital policy change. They demonstrated that soldiers living in overcrowded barracks died at higher rates than men of the same age in the general population, even without exposure to combat. And they successfully reversed this trend with improvements to sanitation and reducing overcrowding. By 1863, the mortality rate among soldiers was less than that of civilian men the same age. That quote is from Nightingale's writing, which shows that not only was she using statistics in ways that were novel at the time, she was a fierce advocate for her patients and for evidence-based hospital reform. She was also the first female member of the Royal Statistical Society. Edwin Chadwick was a lawyer who devoted his life to sanitary reform in England. He stressed the need for fresh, uncontaminated water and adequate removal of sewage. He observed that the living conditions of workers in the industrial age were unsanitary to the point of causing ill health, which he described in an investigative report that he published using his own money. It was an important step towards the realization that societal advancement did not create health benefits for all, and the realization that society needed to accept and then deal with the social costs of technological development, including economic and health disparities between social classes the modern manufacturing era created. Chadwick's report led to the Public Health Act, which promoted social and health equity. While the population of London had increased dramatically during the Industrial Revolution, the government hadn't invested in sewage infrastructure to keep pace with the increasing population. Sewage and other waste were draining directly into the Thames River, which provided a drinking water source for much of London. In 1858, during the Great Stink, British Parliament had to stop their meeting because the stench was so severe. The problem actually got worse after flush toilets were introduced because they increased the volume of human waste. Soon after that, a sewage system was constructed throughout London to divert human waste downstream of the city. While this was obviously an important step to decrease disease transmission from a modern standpoint, at the time, many doctors and scientists still believed in the miasma theory of disease. But fortunately, addressing the smell also addressed cholera and other infectious diseases. A cholera epidemic in 1832 caused more than 6,000 people in London to die of severe watery diarrhea and dehydration. An outbreak in 1849 killed 14,000, and another outbreak in 1854 killed 10,000 more. Physician John Snow believed cholera was spread through infected water, though the bacterium Vibrio cholerae hadn't been discovered yet. He started by marking the location where each person with cholera lived on a map of the Soho neighborhood, which he did by collaborating with Henry Whitehead and other locals. Then he looked for a relationship between the cholera cases and the water pumps, which he suspected to be the source. He noticed 2 areas near the pump that were spared. Interviews revealed that the brewery workers had their own water source and mostly drank beer, and laborers at the workhouse also had their own well there. Another outlier was 2 people in a household who died of cholera in another neighborhood, not easy walking distance to the Broad Street pump. Interviews with family members revealed they walked much further to get water from the Broad Street pump because they used to live there and liked how it tasted. These exceptions to the pattern all lend strength to John Snow's theory that water was the source of cholera, because they can all be explained rationally. Snow presented his findings to municipal officials and recommended that the Broad Street pump's handle be removed to prevent people from accessing that water source. A few years later, Snow performed an additional analysis of that cholera outbreak. The districts with high mortality rates were served by 2 water companies, the Lambeth Company and the Southwark and Vauxhall Company. Both drew water from the Thames River downstream of the city, where it was contaminated with sewage. In 1852, the Lambeth Company moved its water intake upstream to avoid sewage contamination. Snow's data showed the rate of deaths from cholera was more than 5 times lower in areas served only by the Lambeth Company after they moved their water intake upstream. This led him to recommend that all water companies move their intake upstream of London to avoid contamination. By characterizing risk by person, place, and time, then developing and testing a hypothesis, Snow's work on cholera established the steps for undertaking an outbreak investigation still used today in epidemiology. Postpartum infection, also known as childbed fever, is an infection of the reproductive tract following birth, which was often fatal. Ignaz Semmelweis was a doctor at Vienna Maternity Hospital, which had 2 clinics, one run by midwives and one run by doctors and medical students. Women were assigned to one of the 2 clinics on alternating days. The doctor's clinic had an average maternal mortality rate due to childbed fever of about 10%. The rate in the clinic run by midwives was considerably lower, averaging less than 4%. The public knew far more women were dying in the doctor's clinic, so women would beg to be admitted to the midwives' clinic. And if it was the doctor clinic's turn to admit patients, some women would give birth in the streets to avoid the doctors. Semmelweis was puzzled that women who gave birth in the streets rarely got childbed fever, so he tried to find a logical explanation. There was no difference in the procedures used by the 2 clinics. Higher risk births weren't preferentially sent to the doctor's clinic. Women were assigned to one of the 2 clinics on alternating days, so it was random. It wasn't overcrowding because the midwives' clinic was always more crowded. The only difference was that doctors and medical students performed autopsies every morning before working in the maternity clinic, while the midwives' only duties were assisting women in childbirth. Semmelweis's friend suffered an accidental sharps injury from a student with a scalpel. Then he died of an illness resembling childbed fever. Semmelweis suspected the biological matter from corpses was somehow spreading to the live patients. He hypothesized that a chlorine solution, which was effective in ridding the hands of the smell from conducting autopsies, might also be effective in preventing the transfer of infectious material. He instituted a policy requiring all doctors and medical students to wash their hands with chlorine solution before working in the maternity clinic. In 1848, the maternal mortality rate in the doctor's clinic dropped from 18% to less than 2%. Mortality fell to 12.7 per 1,000 births, comparable to the rate of 13.3 per 1,000 births in the midwives' clinic. Although Semmelweis's hand hygiene intervention was a great success in saving women's lives, there was an intense backlash by doctors who were offended by the suggestion that they could be unclean. They also resented that Semmelweis was implying that the doctors were giving the infection to the women. His findings earned widespread acceptance only years after his death, when Louis Pasteur confirmed the germ theory, giving Semmelweis's observations a theoretical explanation, and Joseph Lister, acting on Pasteur's research, operated using hygienic methods with great success. The theory of spontaneous generation, the notion that life can arise from non-living matter, dates back to Aristotle and the ancient Greeks. An experiment by Francesco Redi provided the first significant evidence refuting spontaneous generation. He showed that flies have to be allowed to land on meat for it to then produce maggots. If the meat is protected from flies, no maggots will appear. French chemist and microbiologist Louis Pasteur boiled broth in swan neck flasks to sterilize it, then demonstrated that the intact flask, which allowed air to escape the long neck but didn't allow microorganisms from the air to enter, remained sterile. But if the neck is broken off, allowing microbes to reach the broth, they grow. This showed that microbes are in the air and don't spontaneously generate from sterile broth. Pasteur's experiments irrefutably disproved the theory of spontaneous generation and perhaps put miasmas to rest once and for all. While researching chicken cholera, Pasteur asked his lab assistant to inoculate the chickens with fresh bacteria culture before leaving for vacation. He forgot and also went on vacation. When they got back, they tried using the months-old culture on the chickens. The chickens showed some signs of infection, but instead of all dying like normal, they survived. This showed that the culture was attenuated, made less virulent, and when injected a second time with this aged bacterial culture, the chickens didn't show any signs of infection at all. They were totally fine, showing that the weakened bacteria helped the chickens become immune to the infection. Recognizing that a pathogen's virulence could be increased or decreased was an important advancement in our understanding of infectious diseases and helped pave the way for future vaccine development. While bacteria had been discovered previously, German physician and microbiologist Robert Koch was the first to design an experiment to show that a specific bacteria was the cause of a disease. The postulates for disease causation were originally formulated by the German pathologist Friedrich Henle, which Koch built upon. The Henle-Koch postulates are: the microorganism must be found in diseased but not healthy individuals. The microorganism can be isolated from the diseased individual and grown in pure culture in the laboratory. The cultured microorganism will cause disease when transferred to a healthy, susceptible individual, and the same microorganism can then be re-isolated from the newly infected individual. He discovered the causative agents of cholera, anthrax, and tuberculosis, and he also worked with malaria. He was the first to use an oil immersion lens, condenser, the first to successfully photograph what he was seeing under the microscope, and he developed staining techniques still in use today. Koch initially tried growing bacteria on slices of potatoes, which didn't work so well, but then he started growing bacteria on agar, and his apprentice, Petrie, formalized the Petri dish as we know it today. While the pandemic of H1N1 in 1918 is known as the Spanish flu, it actually started in Kansas. Army recruits in overcrowded, unsanitary barracks preparing to fight in World War I provided a population where the virus could easily spread. Troops from Fort Riley in Kansas were sent to bases in Georgia, Massachusetts, Pennsylvania, and elsewhere, then shipped out to Europe, where they caused H1N1 to spread through France, then around the globe. Wars throughout history have spread infectious disease, but the 1918 pandemic was on a scale never seen before. Classic influenza causes 4 to 5 days of fever, chills, headache, muscle pain, weakness, and sometimes upper respiratory symptoms with cough. Severe complications, including pneumonia and death, can occur, mostly in infants, the elderly, and people with compromised immune systems. But in the 1918 pandemic, there was an unusual peak in mortality among young adults. In some cases, young healthy people were higher risk of death because of their strong immune systems. In an attempt by the body to rid the lungs of the invading virus, an excessive inflammatory response caused the lungs to fill with fluid, so the person drowned. In part because of the fatalities from this acute respiratory distress syndrome-like immune response, more than half of the deaths were in healthy people in their 20s and 30s. It killed up to 10% of the young adults alive at that time. In 1928, physician and microbiologist Alexander Fleming got back from vacation to find that mold had grown on his agar plates of Staphylococcus aureus. He saw a clearing at the edge of the mold where no staph was able to grow. This was similar to how he discovered lysozyme years earlier, an enzyme found in nasal secretions and other bodily fluids that lyses bacteria. The researcher in the same building below Fleming's lab was working with mold at the time, which traveled through the air up to Fleming's lab and got on his agar before the Staph aureus could grow. Early on, Fleming discovered that antibiotic resistance could develop if too little penicillin was used or if it wasn't used for long enough. He cautioned the public and medical community not to use penicillin unless there was a properly diagnosed condition, and that it should only be used in sufficient quantities for sufficient duration to treat the infection. Otherwise, bacterial resistance to the antibiotic would develop. It took years for Fleming to convince others of the clinical importance of his discovery. But during the mid-1940s, the United States and British governments helped support the team at Oxford to develop methods for large-scale production and distribution of penicillin. The World Health Organization estimates that antibiotics add an average of 20 years to human life expectancy. As public health advances shifted what was causing morbidity and mortality from infectious to non-infectious diseases, epidemiologists applied the same methods to chronic diseases. Known as the British Doctors Study, Richard Dahl and Bradford Hill's report published in the British Medical Journal in 1956 demonstrated that the risk of lung cancer was related to the number of cigarettes smoked per day. The risk was 25 times higher in those who smoked more than 25 cigarettes a day than in non-smokers. It's hard to prove a causal relationship in public health, so they started a large prospective cohort study in 1951. It was helpful to use doctors as the study participants because they're required to keep their address updated with the British Medical Register, so less people were lost track of than in a typical population. And they all had access to high-quality healthcare. With 50 years of follow-up time, their cohort study confirmed the relationship between smoking and 12 types of cancer, in addition to vascular and respiratory diseases. They found men born between 1900 and 1930 who smoked cigarettes died about 10 years younger than non-smokers. Dahl and Hill's research on the epidemiology of chronic diseases helped lay the framework for cohort studies as a method to prove population-level associations between an exposure and disease. Polioviruses target motor neurons in the spinal cord and brainstem, causing weakness and paralysis. The most common symptoms caused by polio infection are 1 to 2 days of fever, headache, sore throat, and fatigue. Most people recover, but about 1 in 200 develop paralysis, which can be permanent or fatal if the respiratory muscles become paralyzed. Most cases occur in children under age 5, so many of the people put in iron lungs because they lost the ability to breathe on their own were young children. Poliovirus is highly infectious. It's transmitted by the fecal-oral route, often through contaminated water or food. Infected individuals, including those without any symptoms, can keep shedding the virus in their stool for up to 6 weeks. Polio epidemics used to happen every summer. In the US, polio incidence peaked in 1952, with more than 57,000 cases that year. While there's no cure for polio, many researchers were racing to develop a vaccine. John Colmer started work on a live polio vaccine in 1932, but he rolled it out without a system for monitoring for side effects or even directions for how to administer it when he started producing it for distribution, and at least 10 cases of paralytic polio resulted from his vaccine, 6 of which were fatal. Colmer's vaccine was criticized as dangerous and not approved for widespread use. Soon after, Maurice Brody developed an inactivated polio vaccine. It was tested in Kern County, California, which was experiencing a polio outbreak. Over 1,500 doses were administered. Then a larger trial was undertaken with 9,000 vaccinated kids and 4,500 age-matched controls. The results were promising, but Brody's vaccine was criticized by people who didn't believe that an inactivated vaccine could be effective, and it was soon withdrawn. Following public criticism over his vaccine, Brody was fired from his job and died of a heart attack at the age of 36. Following the hearing on Colmer and Brody's vaccines, a moratorium on polio vaccine research was restored, so progress stagnated for years. In 1950, Hilary Koprowski made an oral live attenuated vaccine, which wasn't approved in the US but was used successfully elsewhere. Jonas Salk built upon Maurice Brody's research and developed his own inactivated polio vaccine. By the mid-1950s, the medical community was more open to the idea that an inactivated vaccine could produce immunity, so Salk didn't face the same resistance that Brody had years prior. In 1954, the Salk vaccine was given to 2 million American children, which was the largest clinical trial ever undertaken at the time. A mass vaccination campaign followed its licensure in 1955. In 1954, there were more than 38,000 polio cases in the U.S., but after just 5 years of the Salk vaccine, cases dropped to 2,525 in 1960. Not long after the Salk vaccine was developed, Albert Sabin developed an oral polio vaccine using a live attenuated virus. But the U.S. favored the injectable Salk vaccine, so Sabin first tested his vaccine in the Soviet Union. Both the Salk and Sabin vaccines are still in use today. While Sabin's oral polio vaccine does carry a risk of a type of polio infection caused by those who have been vaccinated, it's much easier to administer in low-income countries and remote communities without adequate temperature control to ship and store injectable vaccines. In 2022, there was a case of polio in an unvaccinated adult in New York. Vaccine-derived polio was identified as the cause in this American who had not traveled internationally, but was exposed to a person who had received the oral polio vaccine abroad. Oral polio vaccine was removed from the routine immunization schedule in the US in 2000 and from the UK in 2004. Vaccines reduced the global polio incidence to 33 cases in 2018. It was declared eradicated from Nigeria, so it's now only endemic in Pakistan and Afghanistan. That's me getting the late D.A. Henderson to autograph his book, Smallpox, The Death of a Disease, when he came to lecture to my MPH class in 2012. D.A. Henderson earned his MPH at Hopkins in 1960 and returned as a professor of epidemiology and international health and the dean in 1977. He led the World Health Organization's global smallpox eradication program, which started originally in 1959 with an intensified program that started in 1967. D.A. Henderson was also instrumental in initiating the World Health Organization's polio eradication program. Polio has been very nearly eradicated, but as I mentioned on the previous slide, it's still endemic in Pakistan and Afghanistan, with some cases occurring every year. The last naturally acquired smallpox case was in Somalia, and one person died after that in 1978, but she was infected by a microbiology lab conducting research on smallpox. She was working one floor above the lab and was exposed to airborne virus, which also spread to her mother, who cared for her but survived. The ability of laboratories to produce higher quality freeze-dried vaccine, the intervention of the bifurcated needle, which was designed to hold a dose of reconstituted smallpox vaccine in its prongs and puncture the skin to the ideal depth, establishment of a smallpox case surveillance system, and mass vaccination campaigns all contributed to the successful eradication effort. The World Health Organization declared smallpox eradicated on May 8, 1980, almost 2 centuries after Jenner developed the smallpox vaccine. Under D.A. Henderson's leadership, smallpox became the first disease in human history to be completely eliminated worldwide. In the mid-1980s, there was a nationwide panic as people learned about acquired immunodeficiency syndrome, AIDS, for which there was no effective treatment, and transmission was initially not fully understood. Ryan White, a 13-year-old with hemophilia who needed blood transfusions, was one of the first children diagnosed in 1984. Ryan White faced a backlash from parents of kids at his school and others, but instead of retreating from the spotlight, he became a poster child for the AIDS epidemic and the misunderstandings surrounding it. He spent the remaining years of his life working to end the stigma around testing positive and advocating for AIDS awareness. 1996 was a turning point in the AIDS epidemic. Scott Hammer, a professor of epidemiology and medicine at Columbia University, and his colleagues, and separately, Roy Gulick and his colleagues, published papers about the benefit of combining 2 nucleoside reverse transcriptase inhibitors, or NRTIs, with a protease inhibitor, which was a new drug class at the time. This combination of 3 different antiretroviral medications taken together, known as highly active antiretroviral therapy, became widely available in developed countries in 1996. A rapid reduction in hospitalizations, progression of people from HIV to AIDS, and mortality resulted. Also in 1996, the Ryan White Care Act was reauthorized through the year 2000, providing funding and resources to help people living with HIV across the country access these life-saving medications. The advances in understanding how HIV infects cells and the pathophysiology of the disease, in addition to the new pharmaceuticals developed, helped change HIV from the death sentence that people initially thought it was to the manageable chronic condition we know it as today. The COVID-19 pandemic shaped the field of epidemiology in numerous ways. It led to the development of new methods of modeling disease transmission using statistical software in the absence of complete data, and generations that hadn't lived through infectious diseases warranting active public health interventions were trained as contact tracers and used isolation and quarantine to stop the spread of COVID-19 in their communities. The challenges of public health communication brought about by technological advances and political polarization were also highlighted by the pandemic, making clear that young professionals entering the field need to develop new approaches for effective communication with the public in today's media landscape. The study of the distribution of disease and the factors that determine that distribution continues to evolve with technological advances and scientific discoveries. In the last century, we've seen major public health success stories, including water fluoridation, seat belts in vehicles, efforts to prevent and reduce cigarette smoking, and thousands of lives saved from infectious disease thanks to vaccinations. Because of epidemiology and public health, we live in safer, healthier communities.